Hi everyone, this is Lola. I'm the Harvard Site Coordinator for New England MHTTC. Please feel free to introduce yourself in the chat box. And now I'm just going to go over a few housekeeping items before we begin. Oops. So microphones have been muted at entry. If you have any questions during the event, either related to the content or technical difficulties, please use the chat. The session is being recorded and it will be emailed out to all participants once available. If you have questions after the session, please email newengland@mhttcnetwork.org. At the end of the month, we'll send you a certificate of completion for this webinar, which you can use to submit to your particular board for continuing education credits. Again, those get sent out at the beginning of each month, so for any events in February, you'll get that the first week of March. And you can contact ifisher@c4innovates.com for more information on those certificates. These are some acknowledgements. The MHTTC network uses language that is affirming, respectful, and recovery-oriented. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences. Healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear and understandable, and lastly, consistent with our actions, policies, and products. And with that, I'll hand it over to Kesh for introductions.
Kelsey, did you want to say something before me?
Sure. Well, I can just do a brief introduction of the topic that we'll talk about today, which is social determinants of health for psychotic disorders. So for people who don't know me, I'm Kelsey Johnson. I'm the program manager with our Technical Assistance Center for early psychosis programs here in Massachusetts. And I know that social determinants of health are something that I think have a really felt presence in the day-to-day care that happens in our clinics. I know it's something that we talk a lot about. It's something very near and dear to my heart with a public health background. So very excited for us to kind of come together today and think about how these types of social determinants are really affecting the people in our care, and then ways that we can incorporate them into day-to-day care. So Kesh, I'll hand it off to you to do our speaker introduction.
Yeah, thank you, Kelsey. So it's my distinct pleasure and honor to introduce my friend and leading psychiatrist, Dilip Jeste. Dilip Jeste is a neuropsychiatrist. Till a few months ago, he was Senior Associate Dean and Distinguished Professor of Psychiatry at the University of California, San Diego. And so there are many firsts to his credit. He was the president of the American Psychiatric Association, the first Asian American to do so. Recently, a few years ago, when he presided over the latest edition of the DSM during his time. His career is illustrious, dating back 4 decades. And I have to say that my own career was tremendously influenced by Dilip. And I remember with Dilip, I have never told you this, when I was a resident, first-year resident from Bangalore in NIMHANS, I came to Pune for an Indian Society of Psychiatry conference. And I saw this young American psychiatrist who just had come back to visit India, and he was presenting amazing work on the neurobiology of tardive dyskinesia with animal models and so forth. And really inspired me about the power of science and research, and influenced me in many ways in my own career, and continues to do so to this day. Dilip started his research at the NIMH on topics such as tardive dyskinesia, schizophrenia, the heterogeneity of this illness, the neurobiology of this illness, the manifestations of this illness in late life, and then moved on to do important research in the area of aging and cognitive aging, and then moved on to take on an entirely new frontier in psychiatry, and that is positive psychology and psychiatry, in which he became a pioneer. And recently he came out with a book on wisdom. which is really worth reading for everyone. And as a sign of wisdom for many of us, we all need to have that wisdom to, as we learn more and more about psychiatry, as we get into more and more minute details of these complex illnesses, we begin to realize how humble we should be given the large social forces that shape the illnesses that we take care of. And not surprisingly, Dilip has moved on in the last few years to understand and study social determinants of health as they apply to complex mental disorders like schizophrenia, which is something that we all need to learn from him, especially those of us who do early intervention in psychosis, as Kelsey was pointing out. So without much further ado, Dilip, take it away.
Good morning, everyone, and thank you very much, Kesh, for such a kind introduction. I must say that the feelings are mutual. I have been inspired by Kesh's research in schizophrenia over last number of decades, and really some brilliant work in various different areas from psychosocial to biology. And he's one of the few people who wrote actually on exposome in schizophrenia. I think in 2017, that was probably the first article on exposome in schizophrenia that I read. Kesh, your own work has been inspiring, creative, innovative for me and for many other people. So thank you again, all of you, for having me here. I also want to thank Kelsey and Lola for administering the networks. I think these networks are great examples of how to put together a group of people from different fields, different geographic regions. And I'm just delighted and honored to talk to you today. So let me share screen. So I'll be talking on social determinants of health and exposome in psychiatry. These two things are related, and I'll talk about them, but I will be talking mainly on social determinants of health. In terms of conflicts, I don't have any financial relationship with the pharmaceutical industry. One thing I wanted to mention was that part of the slides that I'll be presenting are based on 3 new papers that are just accepted by Schizophrenia Bulletin. So we will have a section on social determinants of health in schizophrenia, and it'll take a few weeks probably before these articles go online. So I would suggest that the journal often requires not publicizing papers until they are online. Nonetheless, I want to present all of these findings. This is not some Nobel Prize winning research or something like that, but just from the publisher point of view, it is important to keep it confidential for the time being till they go online. Okay, so I'm going to begin with some background about social determinants of health and exposome. Then in the next 2 sections, I will talk about these studies on social determinants in schizophrenia that I talked about. They'll be coming out in Schizophrenia Bulletin. And they focus on clinical outcomes, assessment measures, and biology. And finally, talking about some intervention and prevention strategies related to social determinants of health. And I want to make sure that we have at least 15 minutes at the end for Q&A. Okay, so in terms of historical background, the idea that social factors affect health is not new at all. People have known that for centuries. For example, ancient Greeks considered not just physical, but also social determinants of health. And they emphasized supportive environments and healthy public policies. This is one of my favorite quotes by Rudolf Virchow, who actually was a neuropathologist. And he said in 1840, if medicine is to fulfill her great task, then she must enter the political and social life. Do we not always find the diseases of the populace traceable to defects in society? Really so well thought time. But the main focus on social determinants started with 1998 publication by World Health Organization of a report on social determinants of health. And the WHO published several books after that. And really this brought this topic to the fore everywhere. And believe it or not, in the US, 2 years ago, there is a formation of a bipartisan congressional caucus on social determinants of health. Now, what the congressional caucus do, I don't know, and we will all see that. But at least this suggests that people at all levels are appreciating the value and importance of social determinants of health. Much of the work on social determinants of health until now has been done in other fields, not so much in psychiatry. And that's why I think it is important for us to talk about this today. So in 1998, when the WHO first wrote about social determinants of health, they described these as conditions in the environment in which people are born, live, learn, work, play, worship, and age. And these are the conditions that have a major impact on a wide range of health, functioning, and quality of life outcomes, as well as risks. And also importantly, major impact on health inequity. This is a major problem, not just in the US, but across the world, about the tremendous health inequity that exists. And this is even more so for people with mental illnesses. And the WHO said that these factors also provide directions to develop new strategies for prevention. In the book that came out a few years later, the WHO listed some of the main social determinants of health. And these included early childhood development, education, job opportunities, and income. So socioeconomic status, in a way. Social inclusion, racial and other forms of discrimination, safe housing, transportation, neighborhoods, access to clean air, clean water, and access to nutritious foods, and access to decent quality, affordable healthcare. So, I mean, this is not a brilliant science. I mean, any one of us will agree that these are all very important points that affect health. And yet, in the past, medicine has not really paid much attention to them. And especially in psychiatry, I think the interest in this has been much less than in, say, oncology or cardiology. Those two areas have done a lot of research in this area. And I think the social determinants are really even more important for people with mental illnesses than those are for physical illnesses. Several reasons. One is that, as most of you know, 75% of the serious mental illnesses begin in early life. So if you are born with, or if you have in early childhood or adolescence a mental illness, then you are likely to suffer the consequences of adverse social determinants for the rest of your life. So for many more years than a person who develops an illness in old age. Secondly, and this is something that as a society, we should be not just embarrassed, but almost ashamed about, is that in the US, there are more people with serious mental illnesses in jails and prisons than in hospitals. It just shows how our criminal justice system is so flawed that we equate some inappropriate social behavior as necessarily suggesting crime rather than saying that it could be a part of the mental illness. Also, most of you know this, but people with schizophrenia die 15 to 20 years younger than the general population. And this mortality gap has been known for a long time, since Kraepelin's time. However, what is not well known is that the mortality gap between the serious mental illness and general population has increased in recent years. This is a paper we published in journal that Kesh edits, Schizophrenia Research. And so this was a review of the longitudinal studies of mortality in schizophrenia, and shows that the gap has increased since 1970s. And it is not because people with schizophrenia are dying at higher rates. No, what it means is that the general population is living longer. And they're living longer because of improved healthcare, improved environment. But those advantages of social determinants are not being utilized or made accessible to people with schizophrenia and other serious mental illnesses. So that's why the gap is growing. So what are the social determinants of mental health? So they include homelessness, criminal justice system, I mentioned just now, stigma against mental illnesses, healthcare inequities for psychiatric patients. I mean, it's really another embarrassing fact, but the mental health care equity, the Congress passed a law some 20 years ago, and officially it is still the law, and yet insurance companies and others are finding ways in which they don't have to pay for mental illnesses for long enough time, similar to what they do for cancer and heart disease and other illnesses. One thing that has been rarely studied is social media. Social media have a greater impact on mental health than on physical health. And unfortunately, the impact is often adverse. We know of people who committed suicide because of the social media posts. And again, this is something that needs to be researched. And last but not least, an important thing is the positive factors. When you talk about social determinants, people always talk about the adverse factors. Early life adversities, racism, poverty. Of course, these are important. But what about positive factors? Kesh talked about this positive psychiatry. And I really think that is something we as clinicians, no matter what our background is, we must pay attention to the positive factors. Positive factors include resilience, optimism, social engagement, wisdom. And these need to be studied at individual level as well as at the community and societal level, because they have as much impact actually on the adverse factors, but we need to pay attention to them. So is there evidence to say that certain social factors have larger impact? This is one of my favorite slides. This was a meta-analysis published by Julianne Holt-Lundstad, an epidemiologist at BYU, Brigham Young University in Utah. She published this meta-analysis in 2010. And she looked at the various factors that contribute to reducing the odds of mortality. And so here's, you see, so the longer the bar, that means the better the factor, that it reduces mortality to a greater extent. And the top three are social relationship or social connection. Social relationships or social connections have greater impact on mortality and longevity than smoking, alcoholism, heart disease, sedentary behavior, obesity, hypertension. Wow. And this is based on meta-analysis that included hundreds of studies all over the world. So what more evidence does one need to say that social connections are important? And yet, what do we do in our practice in terms of asking or promoting social connection? Very little. We pay all the attention to the other risk factors that were mentioned here. What are true about exposure? So social determinants really started in 1998 with the WHO publication, and the WHO focus was on public health. And so what the WHO wanted to do, very importantly, was the government policies to change. So we reduce homelessness, we eliminate racism, eliminate poverty. In a way, something really interesting, but something similar started from a very different angle, and that's the angle of genomics. As many of you know, in 2003, Francis Collins and Craig Venter decoded the human genome, and tremendously exciting development, no question about that. And there's a lot of really, inspiration, and people felt that actually we now know the causes of the diseases and we'll be able to cure them in a few years. That didn't happen. That didn't happen because people soon realized that actually genome is affected not just by heredity, but is also affected by the environment. Only 50% is actually affected by biology and inheritance, but 50% by environment. And so that led to development of exposomics. So this relates to exposure to social and environmental factors across a lifespan, from conception to old age, with corresponding biological responses. So this is similar to social determinants. Because if you look at the factors included in exposome, they include internal and external environment. Internal environment includes things like microbiome, metabolomics, proteomics, transcriptomics. External factors are specific and general. The specific factors include smoking or tobacco in the air, consumer products, water, diet, where the general external factors include climate, green spaces, urban environment, traffic, social capital, so on and so forth. So if you think about it, this is really similar to social determinant. I mean, it includes environmental factors, but environmental factors are also included in social determinants. For example, climate change is an important social determinant according to WHO. So isn't it nice that we have been talking about this for so long? And yet, how has it changed our clinical practice? Not at all. In clinical assessment in psychiatry, how often do we ask about any of these social determinants, and what interventions do we use for overcoming these adverse determinants and promoting positive ones? Very few. Why? One, because there is no definition of social determinants. There is no, what is social? That is not defined. And to call anything a determinant is wrong. Nothing determines anything. Genes don't determine diseases, and environment doesn't determine diseases. It's really a combination of things that have different impact on different individuals. There is no consensus list of social determinants of health or exposomic factors. The WHO original list included about a dozen factors. Today, their list has grown to about 150. And social determinants has become a buzzword. I've seen a study in which depression was called a social determinant. So I think that's a problem. What are the social determinants, and which ones are really important?
Dr. Jeste, we got a question in the chat to repeat the definition of the exposome.
I'm sorry, what is the question?
Can you repeat the definition of exposome?
Sure. So sorry. So exposome means exposure to social and environmental factors that affect genome. And that includes probably most of the factors that are included in social determinants. So the two are very similar. The exposome, of course, focuses on genome, whereas social determinants have a much broader basis, as we will see, not only biology-wise, but public health-wise. So they are actually more similar than different, but they come from very different angles. So the problems with the social determinants, another is that there are very few valid and pragmatic clinical measures. For example, think about social connections. Do we ask about social connections? Then very few people. At the most, you may ask whether you have social support, that's about it. And that really doesn't tell us about social connection. On the other hand, there are measures that have 100 questions as a measure of social connection. Who's going to use 100 measures, right? So that's the problem, that we don't have valid and pragmatic clinical measures for social determinants. to call anything a determinant or cause, we must at least have longitudinal studies. Cross-sectional studies don't establish cause. They just show the association, right? And there are lack of hypothesis-driven biological studies with appropriate biomarkers. So we haven't done these things in the last 20 years. And that's why social determinants field, same thing with exposomics, hasn't advanced and affected our clinical practice or the policies. So we need to start someplace. And again, actually it has happened much better in some other fields than in psychiatry. So in psychiatry, I'm actually very proud of the APA. 2 years ago, 2021 May, APA elected a new president, Vivian Pender. Dr. Pender, she's on the clinical faculty at Cornell, and she made social determinants of mental health her presidential theme, and she appointed a task force, and I was honored to be appointed the chair of the task force. The task force had clinical work group, research education work group, public health work group, and policy work group. The task force lasted for a year because that was its aim. But after it ended, then some of us have been continuing the work through a network. And this is actually in its infancy. Again, I will welcome any suggestions you all may have about advancing this further. But we already have more than 30 people, scientists, including Kesh and several people from Harvard, Yale, as well as outside people from WHO and Royal College of Psychiatrists, among others. And the goal is to understand the social determinants better. And I'm proud of that in a short time we have had some successes. The task force actually resulted in commentaries on social determinants of mental health and JAMA Psychiatry and American Journal of Geriatric Psychiatry. Our research network have these 3 papers that are coming out in Schizophrenia Bulletin, which are reviews of the current state of clinical outcomes, assessments, and biology of social determinants of health in schizophrenia. And presentations at ACNP, American Research for Geriatric Psychiatry, and the APA meeting in San Francisco. There will be some more. And also, we are helping investigators projects through that. So I really think, I feel very excited about this potential, where we need to start from scratch in a way. We need to start with definition. What is social determinant of health? Define which or list the important social determinants that we need to study, decide how we measure them, and then conduct longitudinal prospective studies. So that's our goal. But this is just the beginning. There's a huge amount of work that will need to be done, and that will take many, many years. But we need to start someplace, and that's the goal. So the goal of this special section that will be coming out in Schizophrenia Bulletin on social determinants of health in schizophrenia is to find out what the literature currently says about these things: clinical outcomes, assessments, and biology. And that will lead to suggestions for what the research should be like. So why did we choose schizophrenia? Again, I think you all don't need to be told that, because you are all already interested in schizophrenia. Because schizophrenia is clearly, it's a serious major illness. It has been called cancer of the mind. And for social perspective, the social risk factors clearly play a major role. Everybody knows that. Early life trauma, for example, has been known for decades as a major risk factor for schizophrenia. Poor socioeconomic status, again, very well known. Another thing that we call it a serious mental illness. But it's not just a serious mental illness, it is also a serious physical illness. We don't realize that. As I said, people with schizophrenia have 15 to 20 years shorter lifespan. What do people with schizophrenia die from? 12% die from suicide. But that means 88% die from physical illnesses. They die from the same physical illnesses that kill older people in the general population. The only difference is that these illnesses occur at a younger age than at an older age. Heart disease, stroke, and so on, cancer, they would occur in the 50s in schizophrenia rather than in 70s and 80s in the general population. So there's accelerated aging. That's, again, that has been known for some time in schizophrenia. And as I said, the sad part is the longevity gap is actually increasing. And actually the main reason for this is not biology, it is really the social reason. That really in the last 50 years, we will all agree, that the environment has improved, no question about that, compared to what it was then, right? People are much more conscious about healthy diet, water, physical health, but those advantages have not been transferred to people with schizophrenia, with serious mental illnesses. And the overall, the limited efficacy of available treatment. I think Ross Baldessari published a very nice review of the treatments over 100 years and essentially showed that the things haven't improved much. So clearly we need to do something about that. And so what are the social determinants? So we started with just look at all the meta-analysis that have been published on individual social risk factors. And we found about 25 of them. Now, obviously, we can't study 25. So in our review for this, we focus on 9 more important ones. And these are early life adversities, social disconnection, racism and other forms of discrimination, neighborhoods, disadvantaged neighborhoods, especially urban and low socioeconomic status neighborhoods, because there is greater violence, poor care, social fragmentation, and so on. Migration, people who migrate, including refugees and asylees. Social fragmentation, food insecurity, homelessness, incarceration. So we selected these 9 mainly because among the co-authors, we agreed that these are important ones. And that doesn't mean others are not important. So we didn't include, for example, things like stigma against mental illness, and that's critical, but it needs to be studied separately. Actually, I should say again, Keshwan is one of the co-authors of this paper. And I will talk about each of these briefly in my presentation now. So what we did was we focused on meta-analysis of these 9 social determinants of health. By the way, we did not find a single paper on social determinants of health and schizophrenia in a broad sense. So the papers that these meta-analysis I'm describing to you about, very few of these papers used the word social determinant. So they were papers on, say, early life adversities or racism or poverty, not as social determinant, but just as some of the risk factors. And nothing wrong with that. But coming back to the need for looking at social determinants in a comprehensive way. Okay. So we found out that the main clinical outcome that people had looked at in the published studies were incidence of schizophrenia, prevalence of schizophrenia, hospitalization, and actually I can't see the last one in my here. Okay, because of the pictures that I see people's. Okay, medium to large, and we found that each of them, and I will give you some details soon, but the effect sizes for each of the social determinants of health is medium to large. Actually, in most cases, large. But there are major limitations to this study. Most of these studies, practically all of the studies are cross-sectional. There are a few exceptions, but there are exceptions. Different studies have used different measures. So you can't really combine them, even for a single factor. For example, social connection, different studies use different measures. And most studies focused on 1 or 2 of these factors. In reality, they all coexist. If you are looking at racism, for example, studies in Blacks or Latinx people with serious mental illnesses, they often tend to be to have lower socioeconomic status. They are also likely to have more discrimination of other kinds, and so on. So they often coexist, and studying each separately doesn't help. And we didn't find any meta-analysis of positive factors as a social determinant. So let me just present briefly the finding regarding clinical outcomes of these social determinants. And again, in the publication itself, you'll find more statistics. But here, I just want to give you a brief idea. Early life adversities. The meta-analysis showed that people with early life adversities, their odds of developing non-affective psychosis are 2.8 times those in people who do not have history of early life adversities. So it means that early life adversities increase the risk almost 3 times. And of course, early life adversities include a bunch of different things. And I'll come back to that shortly. The second factor I mentioned was social network. One of the most commonly used measures was social network size. And the size of the social network was inversely associated with the overall psychopathology. And so using regression analysis, so roughly the G value is negative 0.53. Again, social network size is should not be the only measure. Quality of social network also matters, but there are not enough studies to look at that. Racism. Most of the time, the measure that is used is perceived or experienced racial or ethnic discrimination. Again, different people, different studies have used different measures, but by and large, the odds ratio of developing schizophrenia or schizophrenia-spectrum psychotic disorder, they're almost twice as high as those in people who do not face this discrimination. So the odds ratio is 1.82 and 1.81 for psychotic symptoms and psychotic experiences. Urban versus rural setting. So I talked about the neighborhoods. The neighborhoods clearly impact social determinants. And the psychosis incidence rate is significantly higher in urban settings than in rural settings. Urbanicity is an important risk factor for schizophrenia. Of course, it is a bidirectional relationship. If you have schizophrenia, you are more likely to be in urban settings, your family is more likely to be in urban settings, and so on. The same thing applies to socioeconomic status of the neighborhood. If you live in a lower socioeconomic status area, the chances of developing psychosis are nearly twice as high, 1.78 times higher than people who live in higher socioeconomic status areas. Immigrants versus non-immigrants. Significantly higher risk in immigrants than in non-immigrants, 1.81, 1.82, and it is higher not just in first-generation immigrants, but also in second-generation immigrants. That's actually interesting because that means that it is not the process of immigration only, but it's really the discrimination that is associated. And you see the same thing in refugees and asylees, even greater risk of psychosis. Again, immigration doesn't cause psychosis, but it increases the risk of psychosis in people who are otherwise susceptible through other risk factors. And then, so I talked about 6 of them now. The remaining ones, social fragmentation. There are different measures of social fragmentation. There is social fragmentation index that's commonly used. Again, 4 times higher rates of prevalence of schizophrenia in people who experience the highest level of social fragmentation compared to those with the lowest level. Homelessness. In people who are homeless, the prevalence of schizophrenia is 10%. The prevalence of schizophrenia in the general population is about 0.3%. So look at this, 10% versus 0.3%. That means 30 times higher prevalence of schizophrenia in people who are homeless. And that doesn't mean homelessness causes schizophrenia. Of course, again, it's bidirectional. If you have schizophrenia, you're more likely to be homeless, although being homeless also increases the risk. Incarceration, already talked about that. So that in US, there are more people with serious mental illnesses in prisons and jails than in hospitals. So prevalence of any psychosis in people who are incarcerated is 3.6 to 3.9%, and not 0.3% as in the general population. So all these, the first three I had described, so they were looking at people who experience that social determinant of health and how many of them had schizophrenia. The food insecurity is looked at somewhat differently. In the sense, what they did was they looked at the prevalence of food insecurity in people with versus without schizophrenia. And they found, of course, that median prevalence of food insecurity is much greater in people with schizophrenia, nearly half of them, compared to those who do not have psychotic disorder. So you'll see that consistently high association with this adverse risk factors with schizophrenia. So those are the association clinical outcomes. What about the assessments of these? Because that assessment is critical, right, to come to any conclusion about the prevalence or incidence, social determinant, and the illness. So we looked at the assessments in all those 9 outcomes, and we found that for some of these outcomes, there were good measures. Early life adversities, social disconnection, racism, social fragmentation, food insecurity. And the measures that were used were self-reports or interviews or some rating scales that were used. But the assessment measures were very heterogeneous. The number of items ranged from 1 to more than 100. The time required varied from less than 5 minutes to more than 60 minutes. And you can see that if you can't do anything in less than all the social determinants in less than 5 minutes. But more than 60 minutes is too much. In clinical practice, we don't get reimbursed for spending 60 minutes on assessing social determinants, right? The internal consistency reliability is not bad, 0.68 to 0.96, in only for those measures which actually examined that. Number of measures didn't do that. And for other social determinants like urbanicity, low SES, migration status, homelessness, incarceration, there were no subjective measures. They looked at public databases or targeted sampling. So the limitations of these assessment measures are the varied psychometric evaluation, reliability, validity, pragmatic value. It has not been studied for all the measures, but also where it has been studied, it has not been studied in people with schizophrenia. So something may be reliable and valid in the general population, but is it valid in people with schizophrenia? That needs to be studied separately. Few of the studies did that, many didn't. And most of the studies evaluated these only once. So you don't even know the consistency of these measures. So as I said, so some of these psychometrics were not tested in people with schizophrenia or other SMI. The measures that were used are not always the best measures. For example, childhood trauma. I mean, this is one of the most commonly assessed social determinant, and one of the most commonly used measures is CTQ, childhood trauma questionnaire. The larger version has 70 items, which very few people will use. The shorter version has 21 items. That's okay. The problem with this is that it mostly focuses on childhood abuse and neglect. The childhood abuse and neglect are important traumas, but they are not the only traumas in childhood. Prenatal, natal, postnatal, parental psychopathology. There are so many things that are not included in childhood adversities in many of these studies. Social disconnection. The measure may take anywhere from 30 to 90 minutes. Racism. Most of the studies looked at individual experience or perception of racism. There is no community-based measure of racism. Food insecurity, this was based on household food insecurity. That's what the CDC does. But actually, food insecurity varies within a family. If there is one person with schizophrenia, that person will have more food insecurity than other 6 people in the family who do not have mental illness. And for things like urbanicity, low ACS, there were no subjective measures. So what should we do? I think the future research should include there should be unified social determinants framework with consensus definition. Which social determinants are important and how do we define them? We should look at multiple facets for measuring that. Self-report based measure, informant report based measure, some objective measures, which may need technology, which will be great, using apps, for example, or even iPhones, and community-based measure. We call this social determinants. So how can we not measure them at a community level, right? Reliability, validity, sensitivity to change with effective intervention, pragmatics, again, very important. How long does it take to complete? How many social determinants we want to assess, and who will assess them? I don't think we need a physician or psychologist or a nurse to do these assessments because they don't have time. There's something called social prescribing in Europe. We can train some other people who can do this over a longer period of time. And again, the values should be not in general population, also in schizophrenia. And of course, we need to educate and train people in the use of these factors. And again, positive things. I mean, it's really sad that there are no studies of family or community-based resilience or other factors like compassion, wisdom, and so on. Assessment of positive, even at individual level, we don't do that. We only ask about what is wrong with the patient. We don't ask about what is right with the patient, what the patient likes about himself or herself. What are their strengths? And the EHR evaluation only include adverse ones, and only because they happen to be demographics or some other clinically relevant factors. Okay, so much about the clinical side of the research. What about biology? So the biology is actually in very primitive stages in terms of biology of social determinants of health. I mean, it is the piecemeal studies. And what is needed is really bringing them together to look at biology of social determinants. But we found that there are 4 major systemic pathophysiological processes that seem to underline many of these social determinants. Social epigenetics, allostatic load, accelerated inflammation, and microbiome. I'll talk about each of these very briefly. And these general systemic processes, they affect the brain. Some people have described what is called social brain, certain parts of the prefrontal cortex, temporal lobe, and limbic system that are involved in social functioning. And so studies show that there are structural changes, functional changes, neurochemical changes, and changes in plasticity as a result of the systemic pathophysiological processes, and that may lead to the adverse outcome. So this is the model that we have presented, that social determinants like early life adversities, social disconnection, racism, poverty, food insecurity. And this is right now, this is a speculation. Again, we need longitudinal prospective studies with multiple different things to prove that, but this is something that is at least a testable hypothesis. I'm not saying we are presenting definitive evidence for that. No, we are presenting something that should be tested. Okay, so these social determinants impact social epigenetics, allostatic load, accelerated inflammation, microbiome, and these then would impact structure, function, chemistry, and plasticity of the brain, and that leads to then the clinical outcome, such as towards physical health, mental health, cognitive function, increased mortality, and so on. And of course, these clinical outcomes impact the social determinants. So, for example, social disconnection, social isolation, and loneliness increase the risk of schizophrenia. But if you have schizophrenia, that makes your loneliness and isolation worse, right? So it's a bidirectional relationship, and that applies to biology too. Okay, so something briefly. So social epigenetics. You know, when the genome was described, there's a lot of excitement. The genome will solve the problem. people realize that that's not the case. Actually, the environment is equally important because the environment affects DNA. It doesn't affect the sequence of adenine, guanine, cytosine, thymine, but through mechanical processes like addition of a methyl group, it changes the expression of the gene. And it can make the behavior, the gene-related behavior, silent or activate. And these changes may be permanent or reversible. And this is even more fascinating. These processes may be heritable in some cases. So you're not only affecting the individual, you're affecting the subsequent generations. Wow. Again, I'm going to skip some of these things just for the sake of time, because I want to make sure we have time for Q&A and discussion. What about allostatic load? I mean, this is well known and anybody can understand, when there are toxic stresses, which occur during sensitive developmental periods. And they produce clearly enduring structural changes and physiological dysregulation leading to health problems. So that's not a surprise that stress would produce health problems. How do we measure that though? I mean, luckily, again, the field has doing well. So there is now a commonly used index of allostatic load that is proposed. It includes cortisol, epinephrine, norepinephrine, systolic and diastolic blood pressure, and BMI, body mass index. These are not perfect, and there would be better ones in future, but let's at least have something that is consistently used. Accelerated aging. This is really a major thing. As I mentioned, people with schizophrenia die young. They die of the same diseases that kill older people. The diseases occur earlier. This suggests that person with schizophrenia is aging faster. 45-year-old person with schizophrenia is like a 65 or 75-year-old healthy subject. And so that reflects accelerated aging, and inflammation plays a major role in this. So this is called inflammation. So there's increase in systemic chronic inflammatory state, and that affects the biological aging process. Again, we need to have consistent measure. Just as I was talking about social determinants, clinical side, we must have reliable and valid measure. We must have the same thing for biomarker. We must have reliable, valid, and pragmatic measures. So again, there is good work done in this area by various scientists. So there are now good blood levels of cytokines, especially high sensitivity C-reactive protein, interleukin 6, interleukin 8, TNF-alpha, telomere length, although telomere length is now somewhat questionable as a measure of aging. Epigenetic clock is actually attracting more attention. Again, none of these biomarkers would be perfect, but we need to get some reliable, valid data. And then as science advances, the biomarkers will improve also. Microbiome. I think microbiome is becoming increasingly important. And my case is that in the near future, it's going to have a major impact on our healthcare. So what is microbiome? Microbiome is a collection of microorganisms, bacteria, fungi, viruses that live in the body, especially in the gut, or on the body, including our skin. So and that groups genetic content. And there is something important, that is gut-brain axis. Again, tremendous research in the exciting research in this area that clearly shows bidirectional communication between the gut microbiota and brain through a network of chemical transmitters, neural connections, immune signals, and so on. Really considerable research that shows the possibility of future interventions depending on probiotics. Right now, we don't have any good probiotics, in spite of their claims in the supplements. But in future, I think we are bound to have some terrific probiotics that could impact health. I just want to give you a few examples of how to tie together the biology, social determinants of health, and outcome. And again, I just said, this is all speculation. There is no solid evidence, but this provides a stable hypothesis. And again, that is what is needed in our field. Okay. For example, there is something called Bayesian model of paranoia among migrants. So when people migrate, just like I did, we migrated from India and from any place. So we come here with our prior beliefs and social trust. But that is threatened by the new host culture. Threatened may be a strong word because it's not always adverse. I mean, there is often it is positive. Nonetheless, it is affected. No question, that is affected by the new host culture, both in terms of beliefs and social trust. And that it can lead to overinterpretation, misinterpretation of ambiguous situations on both sides. For example, if the migrant does something that was normal in their culture, but is considered abnormal in the host culture, then that will generate some negative reaction in the host culture. And same thing would happen otherwise, in the sense the host culture does something that is considered bad by the migrants, so they would view that negatively. And so that leads to increased lack of trust on both sides. And that leads to stress-induced increased striatal dopamine activity and reduced prefrontal dopamine release. This has been shown more in animal studies than in human studies, but there are human studies also that support this. And that would increase the risk of paranoia in susceptible migrant. So people who already are at a risk of schizophrenia because of family history, early life adversities, so on. And if they experience these things, then there is increase in striatal dopamine activity. So you can see how biology, through social determinant, can impact psychotic illness. And of course, this becomes a vicious circle. There is something called social defeat hypothesis of schizophrenia. So according to this, negative experience of social exclusion, and we all agree that social exclusion is bad, right? And people may be excluded because they're migrants or because they are different, they belong to different race or ethnicity. And just social exclusion leads to sensitization or increase in baseline mesolimbic dopamine activity. Again, there are animal studies that have clearly shown that. There are animal models of social exclusion, for example, and you can see that. And that's in change in mesolimbic dopamine activity would increase the risk of schizophrenia in new migrants. So this is the social defeat hypothesis, but there are objections to this hypothesis. One is that there is no clear definition of what is social defeat and how do you measure social defeat? Apparently, it is impossible to measure social defeat. Anyway, so just to give you both sides of argument, something like that. One other example, and stop with that one here, this one, racism and health. Again, this is emerging science, and there's a lot needs to be done. But it's a really nice paper published by Muscantel and colleagues, and this is kind of overview of the literature. This is not a specific study. And again, all of the published literature has limitations. So any conclusions we draw will have limitations. Nonetheless, there are strong suggestions that there are neural and inflammatory mechanisms linked racism and health. Racism may disrupt connectivity among different networks. For example, salience network, executive control network. And this leads to greater sympathetic nervous system signaling, increase HPA axis activation, and increased expression of pro-inflammatory genes, which will lead to more inflammation and inflammation-related other things. And so the thing that I described earlier associated with allostatic load, epigenetics, inflammation, and accelerated aging. And when they persist, naturally, they are going to lead to chronic physical as well as mental health condition. Let me skip this again, because I want to leave enough time for discussion. So there are actually some, so the biology is definitely in early stages. But this is not only exciting, we must try to understand how the social determinants affect biology, and through biology, how they affect outcome, because that will lead us to develop new interventions and prevention strategies that we don't currently are not even thinking about. And one of the advantages actually or importance of studying social determinants is prevention. And actually that was the point of the WHO, that by studying social determinants of the risk factors, we can do something to that. And so when we talk about prevention, typically we talk about three types of prevention: primary, secondary, tertiary, right? Primary prevention is preventing occurrence of an illness. Secondary is detecting a disease early, preventing it from getting worse. And tertiary is softening the impact of ongoing illness, injury through rehab. I think we all know that. There are two additional ones that have been understood recently: primordial and quaternary. So primordial occurs before primary, and this is preventing risk factors. Primary prevention is preventing disease. Here, you actually prevent the risk factors for the disease. And that's where the social determinants are a great example. We can prevent early life adversities, for example, by ensuring the best possible prenatal, natal, and postnatal care, for example, right? Quaternaries, it comes beyond tertiary. So avoiding complications or adverse effects on intervention. All types of prevention are possible in mental health. We don't think about psychiatry as something where we can prevent something. We can. Example: primordial prevention. Actually, the best example would be the social determinant of health, especially something like early life adversities. I mean, other things also, things like racism, poverty, hunger, homelessness, but that's going to take decades. Maybe our congressional caucus will solve all these problems. Let's hope so. The primary prevention is actually, even in old age, is possible. For example, we know that the risk of depression increases following myocardial infarction or stroke. So we can start preventing depression after people have myocardial infarction or stroke. We don't need to wait till they develop depression. And prevention doesn't mean giving antidepressant. It means psychotherapy or some support that we give to the patient and the family. Secondary prevention, suicide attempt. I mean, if somebody attempts suicide, then we can prevent future suicide attempts, right? Relapse in schizophrenia, bipolar, substance abuse. Tertiary, reversible dementia, where we detect the cause, which may be vitamin deficiency, for example, and then we can do something to that. Quaternary is very feasible. It's an iatrogenic condition, treatment-induced conditions like tardive dyskinesia, anticholinergic delirium. So all of these preventions are possible in psychiatry. We need to practice them. That's the first thing. Let me skip this. So psychotherapy. This is something really just I find incredibly fascinating. One of the most fascinating things experience or heard about is we talked about social determinants of health, right? And if when a patient is coping with things like racism, poverty, already had early life adversities, what can we do to the patient? So we can try to improve their functioning through environmental manipulation, but also through psychotherapy. And so psychotherapy is a psychological treatment, right? Well, new research has shown that actually psychotherapy affects genes at any age. So early life adversities, we know, including trauma or other things, the stresses, they clearly affect gene, and that's well known, the epigenetics of early life adversities. What is not known, and also these epigenetic changes, as I said, can be permanent, they can be reversible, and they can be transmitted across generations. Recent research has shown that psychotherapy can be associated with epigenetic changes. So the changes that are produced by trauma, changes in the gene expression, those changes can be reversed by psychotherapy. And just like trauma-induced epigenetic changes, psychotherapy-induced epigenetic changes can also be permanent or reversible, and they can be transmitted across generation. Again, this is research in very early stages. And so far, and this is, I'm not presenting these as well-known fact, evidence-based facts, not at all. But there is some evidence that this is possible. It may even be probable. And I find that really, as I said, one of the most exciting areas. It gives, and I should mention here, actually, that I got this slide from Cesar Alfonso, who is a professor of psychiatry at Columbia University. He's the president of the World Federation for Psychotherapy. And actually, I happen to be the president-elect for the society. And so I'm getting interested in psychotherapy. I mean, I have been interested in psychotherapy for a long time, but really looking from the biology perspective, because typically we think about social on one side, psycho on one side, and bio on the third side, psychobiosocial. This is a great example of psychobiosocial. Psychotherapy affecting epigenetics, which would improve psychological behavior as well as physical health. So there is a study that showed that 12 weeks of CBT for anxiety disorders in children resulted in decreased methylation levels of one specific gene. Another study, actually this was a more recent study, that found that successful treatment of PTSD using trauma-based psychotherapy in soldiers, successful treatment was accompanied by significant changes in DNA methylation at 12 different methylated regions in the genes. Again, this is very early research. This is research in its infancy, but this is really exciting because typically when we have a patient who had early life trauma, we say, oh, there's nothing we can do to that. Well, if this proves to be true, it means that we can do something even to overcome, negate those traumas. Again, nothing is simple, and there will be a lot of complications, and things will not go as easily as this. Nonetheless, this is something exciting. Okay, so after that, now I just want to present to you some stray examples of psychosocial intervention that may be helpful and that may be interesting to consider. Talked about social media and how harmful they can be. Bullying has become a major factor, including cyberbullying. And there's a very nice study done in Spain. They developed something called Cyber Program 2.0 to prevent bullying and cyberbullying. Structured 19 one-hour group sessions, including role-playing, brainstorming, case study, guided discussions. This was a randomized control trial, by the way. And they found the Cyber Program 2.0 increased empathy and reduced amount of bullying and cyberbullying compared to the control condition. It's a great example of how we can change the community or social behavior through interventions. Racism. This was not an intervention, but it's a cross-sectional study that's actually meaningful. So this is a study of 11 public middle schools with more than 70 sixth grade classrooms with varying ethnic diversity. They found, and this is a large sample size, 5,000 plus African-American students, 5,000 plus Latino students, and they found that students who were safer in school, less harassed by peers, were less lonely, had higher self-worth, were those who were in diverse classrooms. So that diversity of the classroom improved their well-being and performance. Let me skip this. And so, okay, the good news is that there are some exciting campaigns that are going on, like WHO Network for Age-Friendly Cities, and also there is a network for compassionate communities. So I'm approaching the end of my talk, just a couple of slides. So I think the future, so we need studies of epigenetics through psychotherapy, anti-inflammatory therapies, microbiome and probiotics, oxytocin. Again, it plays a major role in social connection, brain stimulation. And of course, things need to happen at the public health level also, community level interventions, advocacy at local, state, central government levels, media outreach via social media, international collaboration. And this is my last slide. So I said that, we are establishing this global research network on social determinants on exposome. And the goal is to develop valid and pragmatic clinical assessment. So they have to be valid, but they also have to be pragmatic in order to be meaningful. Same thing with biomarkers. PET scans are great, but how practical are they, right? So we need something, and the blood-based biomarkers, they may not be ideal, but if they can suggest reasonably well what's going on in the brain, I think they would be far more useful, right? Development of interventions. Interventions with new thinking. Interventions, again, this psychotherapy, epigenetics I mentioned. Another is microbiome. There is some absolutely amazing research going on in microbiome in other fields, and including animals. For example, studies have shown that if you give probiotics, that reduce the risk of obesity and diabetes to pregnant mice or pregnant rats. Okay, so talking about giving probiotics that reduce the risk. Compare them with probiotics that increase the risk. And this is only true in animals. Again, as I said, there are no probiotics we know in humans that will do that. In animals, there are. Studies show there are randomized control trials of pregnant mice and pregnant rats who were given these probiotics. 2 generations later, the risk of diabetes, obesity, heart disease differed significantly between the 2 groups. So that means that the microbiome can have impact, the diet we eat can have impact, not only our own health, but the health of our grandchildren. Again, this is preliminary research, very in the early stages, and there will be lots of problems, but still, we need to think outside the box. That's the main point. Public health care for prevention and socioeconomic policies for promoting equity, diversity, and inclusion. This is really important. I mean, not only the healthcare system, but healthcare inequities are embarrassing and shameful, and need to do something about that. And that needs to happen really at all levels, but local level as well as central level. So thank you very much for your attention, and thank you for giving me the opportunity to talk with you. I look forward to any comments, suggestions, questions you may have. So thank you, and I'll stop share.
Thank you very much, Dilip, for that really tour de force overview of what is a very, very complex topic and important topic. So there are a number of questions in the chat that I'm going to bring up. So one of them was about there needs to be, it's more of a comment than a question. There needs to be more of a focus on the impact of structural racism as opposed to perceived racism. Do you have any thoughts on that?
No, I think both are equally important. I think, I mean, there is no, in the sense, structural racism is critical. I mean, it's more important than anything else. No question about that. I think we got to be doing something because I mean, what is happening in the world today, the news we read from time to time, it really sends shivers down the spine. I mean, how can society like ours allow something like this? It is, and it is preventable in the sense, we know, again, the studies clearly show how discrimination produces biological effects, shortens the lifespan. I mean, even during COVID, what matters? Somebody said that very nicely. The longevity is affected less by genome than by the zip code. and zip code reflect racism as well as socioeconomic status and other types of discrimination. So there's no question that something must be done at the structural racism level. But that has to be done by the Congress, the legislature, administration at all levels. And of course, at the institutional level, it must happen at all. But I think individual perceived racism is also important, but because whether we like, unfortunately, racism is going to be there for some time. We can't eliminate it. What do we do to the patient that we see today? We need to have some ways to help them cope with racism, fight racism, and some kind of intervention so that they get less stressed out, they get better care. And that's why I think also one of the problems with research, the published research, is that there are very few studies. Most of these studies have looked at perceived racism as outcome measure. And that was one of my criticisms of the literature, is that they must also look at community racism that existed.
Thank you, Dilip. So one other somewhat related question is the overdiagnosis of psychosis rather than affective disorders in African American and immigrant populations of America. Do you have any thoughts on that?
It is that's a very good point, and there has been some discussion in the literature actually about bias on the part of clinicians. The clinicians are more likely to diagnose schizophrenia because the person happens to be Black or Latinx or some other immigrant. And to some extent, that's probably true, but I don't think that's the main reason, because a number of studies actually have looked at that specifically and looking at different, the skin color of the clinicians and how does that relate to the diagnosis. And it shows that it goes beyond that. I think the issue is, it is definitely, the reason is not biological. Definitely not. In the sense, the incidence of schizophrenia is same all over the world. It is same in Africa as in Australia, as in Europe, as in North America, South America, Asia, and you name it. That's why, biologically, there is no reason for a difference. The reason that we see differences is social. And then starting with early life adversities to lower socioeconomic status to social fragmentation, discrimination, so on and so forth. All of these factors actually increase the risk of psychosis in people who are immigrants or people who face racial and other types of discrimination.
Thank you. So there is one other question. Let's see here. Do you know any examples of a clinical program treating schizophrenia that does a good job of assessing for social determinants? A program that does a good job of doing interventions designed to reduce impact of social determinants?
I'm sure there are programs like that. And so it reflects my ignorance rather than non-existence of such programs. I mean, I've not been looking at that. I'm more on the research, but it's a great question. I mean, I would actually welcome people telling us that they have a program of this kind, because we need role models. And I would love to hear from people. And, if you can, please email me if you think, or if you know of somebody else who is doing that. We really need role models. And I think they need more publicity. We got to be able to do that.
I mean, I can definitely give a shout out to our team here in Boston at Boston Medical Center. I know just as a general hospital, Boston Medical Center thinks a lot about this, and they have connections with like criminal justice diversion or support for people following criminal justice involvement, a community food pantry that's connected to the hospital, things like that. I mean, I was particularly surprised by the high rates of food insecurity that you guys found for people with schizophrenia. So I think that because of the wide range of what social determinants look like, I think the interventions also have to look very different and span a lot of different areas. But I mean, I agree with you. I think that a lot of places are noticing these in different areas and accounting for them in the ways that they can.
And I think we really need, because I think our healthcare system is so broken. I mean, we have 15 minutes to see a patient and for which person gets reimbursed. I mean, what can you do in that 15 minutes? So we need to find ways in which we can do that. That's why I said that if the assessment don't have to be done by physicians or psychologists or nurses, they can be done by, some assistants, graduate level, who can be trained in those assessments. So they can spend longer time to do that. But again, we real role models. I think people need that. So I would welcome everybody to come up and brag about their program. That'll be great.
And I appreciate especially Olivia's point in the chat too of getting a system for these types of services to be paid for, ideally, not related to grants, but through insurance, because of what we know of how related they are to just general overall health. That was another thing I think I particularly appreciated is the how you highlight how schizophrenia is also a physical health disorder. I think that really stood out to me.
Cool.
Yeah, one thought I have, in relation to this is, I think you made a very, strong point that, even though it might appear that social determinants are difficult to intervene because a lot of those factors are beyond our control. Some of those, if identified in the clinical setting, might be the focus for developing interventions. So the question I have is, are there ways in which one can potentially identify those who might be at a particular risk of either worsening or developing a new psychosis in the context of multiple social determinants of health? In other words, develop a way of predicting, psychopathology in the context of these factors, and then developing a way of developing a personalized intervention, so to speak. So one way could be many of these social determinants are interacting with each other, and they are not independent, but some of them are probably somewhat independent. If there is a way of creating a social environment determinant index, if you will, just like a polygene score, like a poly-environmental score, that could help us identify people who are particularly at a need for more personalized interventions. And secondly, can we develop a way of treatment planning that takes into account the individual specific social determinants for that particular case? Because not everybody has every problem, but if we can identify who are the ones that are most likely to be affected by these factors, that could help us treatment planning, so to speak. So it's kind of a personalized care or individualized care.
It's a great point, Kesh. It's a great point. I mean, I couldn't agree with you more. So what we need is, actually in the exposome area, they're focusing actually on the environmental composite index and how that affects genes. And I mean, research-wise, that's great. The problem is that which ones do you include? And the answer is actually it goes in both directions. I mean, in a way, on the one hand, you want to include number of them. On the other hand, by including number of them, you make it very difficult to do anything about that. So should we not? And there is no right answer to that. I think it is that we need models for both. Something where but your point though is very well taken regarding identifying people who are at a high risk. And they are, I don't think you can do randomized controlled trial because that would be unethical. But if there is at least, if you can do longitudinal studies of interventions, focusing on some specific, we can't treat all of the social determinants, but if we could just select a few that are relatively modifiable and where through psychotherapy, family therapy, or some community-based intervention, things like that. But we need to do it in a practical fashion, but also in a replicable fashion. So we need to define what we are doing, what intervention, what measures we are using, including some biological measures, and see what impact they have. So
Yeah.
the risk there is, on the one hand, we may try to do too much and then nothing will happen. And that is what has happened in the last 20 years. Nothing has happened because you think about social leaders, so many of them, so much impact, nothing happens, right? But on the other hand, just looking at one or two doesn't help either, because they are also interrelated. So again, this is an area that needs considerable research. And that's why I hope network like this, we can work together, bringing in people from different areas and think about where the future goes.
Yeah, what comes to my mind is, the usual teaching that stresses cannot be easily turned off, but the resilience towards those stresses could be built. So if there are broad-based ways of enhancing individual stress, that kind of a resilience building forms of psychotherapy could be worth testing in a randomized trial, so to speak.
Absolutely. That whole approach, the philosophy of that approach is something I like, which is, don't talk about how to reduce the adverse social determinant. Talk about how you can enhance the person's resilience and ability to cope. So that is something positive, right? How to improve their social support, how to improve their social connections. Those are the things we should talk about, and not just how to reduce the adverse determinants.
I'm sure there are some other questions from the audience as well. If you have not put them in the chat, please unmute yourself and ask.
We do have one here from Corey asking about, or to comment on what you think of the overlap of smoking as both a social determinant and as a risk factor in schizophrenia.
Yeah, absolutely. There's definitely smoking, both secondhand smoking and first-hand smoking, clearly are an important risk factor. If you smoking is person's behavior, so that itself is not social. But of course, if you live in a surrounding where everybody smokes, then clearly you're affected. By the way, cannabis has been shown to be a major risk factor for schizophrenia in youth. There's a lot of literature showing that the risk is higher with cannabis than almost any other substance that is abused by teenagers or younger people. So, as I said, I was describing only the 9 social determinants we selected because we couldn't, but there are 15 others that should be studied, and they include definitely smoking, cannabis use, mental health stigma, and so on.
Great.
And then another question in here from Shelby. We may only be able to do one or two more, but saying, do you have any thoughts on what types of upstream approaches could be implemented to reduce the severity of adverse experiences and improve protective factors to reduce the impact of these experiences on SMI? An example she gives are improving emotional regulation and resilience in elementary schools rather than intervening later in life.
Absolutely. I think that's really where we need. There's one example I showed you in the slide on study of middle school children, that when in diverse classrooms, everybody did better. And not only in terms of their well-being, but their performance. And so that's an example. And I think we clearly need this kind of interventions. For example, from a different angle, I study wisdom, and compassion is one of the important components of wisdom. And in medical students, and compassion includes self-compassion, by the way, there are now training courses in some medical schools for medical students on empathy, compassion, self-compassion. And we shouldn't wait till medical school. We should start that at kindergarten or even earlier. So I think we need to really stress the positive values. We don't do that. Right now, our society's whole focus is on structured academics. For example, a physician, the best physician is somebody who is the best diagnostician or best therapist, not somebody who is most compassionate and who gets along well with people and helps them. Just like in sports, one who is a champion who beats everybody else gets an award. Nobody gets an award for sportsmanship. And so we really need something at that level where we don't just teach them reading, writing, arithmetic. We also teach the other values which are important for societal, not just survival, but thriving.
Thank you very much, Dilip. I think we are at 1 o'clock. Really appreciate your insightful overview and answer all our questions. Look forward to the papers. Many people are looking forward to your papers in Schizophrenia Bulletin, and also whenever the slides become available.
Sure.
Thank you.
Thank you. Thank you. I really appreciate it. It was a pleasure to talk to this wonderful audience. Thank you.
Bye-bye.